systematically integrating kidney stone prevention into routine pediatric primary care. Most pediatric kidney stones are preventable through early identification of risk factors and proactive intervention, yet primary care currently lacks systematic approaches to screening and prevention. This represents a massive missed opportunity. Analyze current gaps honestly. Kidney stones aren't included in standard well-child visit screening protocols. There's no checkbox for stone risk assessment on typical well-child templates. Family history is inadequately assessed. Pediatricians may ask broadly about kidney disease, but rarely specifically about kidney stones. Dietary counseling focuses overwhelmingly on obesity and diabetes prevention without considering stone risk, even though many dietary recommendations overlap. Implementation of integrated screening protocols could transform outcomes. Routine family history of kidney stones during well-child visits takes seconds and identifies high-risk children immediately. Urinalysis at key ages, perhaps at age 5, 10, and 15, could detect early metabolic abnormalities like hypercalciuria before stones develop. Dietary assessment tools identifying high-risk patterns, excessive soda consumption, inadequate water intake, high sodium processed food reliance, flag children needing intervention. Intervention opportunities exist throughout childhood. Anticipatory guidance about hydration during infancy establishes healthy patterns from the start. Parents learn that water is the appropriate beverage choice. Dietary education during early childhood, when eating patterns are forming, has lasting impact. Adolescent counseling addressing energy drinks, supplements, and other stone risks particularly relevant to teens targets age-specific concerns. Practical primary care tools would facilitate systematic prevention. Risk assessment questionnaires completed by parents at checkups screen efficiently. Age-appropriate hydration goals give families concrete targets. For example, a 7-year-old should drink approximately 1.5 liters of fluid daily, primarily as water. Evidence-based dietary recommendations for stone prevention that primary care providers can confidently share with families must be widely disseminated and incorporated into training. The medical home concept positions primary care as the coordinator of care. Primary care pediatricians don't need to become kidney stone experts, but they should identify high-risk patients and coordinate with pediatric nephrology for those who need specialist care. Ensuring appropriate referrals when concerning features appear, blood and urine, family history of stones, metabolic abnormalities on screening, prevents delayed diagnosis. Long-term monitoring of children with stone history ensures recurrence is caught early and prevention strategies are maintained. Healthcare system changes are needed to support this prevention focus. Payment models currently reward reactive treatment over prevention. A stone episode generates significant revenue through imaging, procedures, and specialist visits, while preventing that stone generates minimal revenue. This perverse incentive must change. Integration of nutrition expertise in primary care through embedded dietitians or easy access to nutrition consultation would improve dietary counseling substantially. Public health campaigns educating families before problems develop create awareness that individual healthcare visits alone cannot achieve. Let me share success stories because they demonstrate feasibility. Pediatric practices implementing systematic stone prevention screening have documented reduced stone incidence in their patient populations. Children identified at risk and provided with preventive guidance show lower rates of stone formation. Children whose kidney damage was prevented through early intervention following screening represent lives fundamentally altered for the better, though these prevented cases are invisible and uncelebrated. The vision is clear. Kidney stone prevention should be as routine as immunization schedules in pediatric care. We know the major risk factors. We have effective prevention strategies. What we lack is systematic implementation. Primary care pediatrics is perfectly positioned to lead this prevention effort. These clinicians see children regularly throughout development, have established trust with families, and are trained in prevention and health promotion. Building stone prevention into well-child care requires minimal additional time, requires no advanced training, and offers substantial benefit. The path forward demands action at multiple levels: individual pediatricians incorporating stone prevention into practice, professional organizations updating well-child care guidelines to include stone risk assessment, payers covering prevention services appropriately, and public health systems creating awareness campaigns reaching all families. This is achievable. The question is whether we have the will to prioritize prevention over profitable reactive treatment. Our children's kidney health depends on answering that question correctly.